The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this new webinar of the Maternal Health Supplies Caucus. This is Milka Dinev and I support the Maternal Supply Caucus of the Reproductive Health Supplies Coalition. This morning or afternoon for some of you, we're welcoming MSH, Management Sciences for Health, Jane Briggs, who will be introducing her co-presenters, Eric Jamera Nabugusi and herself. This webinar, as I mentioned, is in partnership with MSH and through the Innovation Fund project that they have implemented in the past year. This webinar is being recorded and a link to the audio and video will be sent to all members of the caucus and to all the attendees in a couple days. You are most welcome to write your questions in the questions box at the right-hand side window of your GoToWebinar platform. So let me introduce our panelist, Dr. Jane Briggs. The microphone is all yours.
Great, thank you, Milka. Good morning, good afternoon, good evening to everybody on the webinar. As Milka says, my name is Jane Briggs. I'm a Senior Principal Technical Advisor at MSH, and I play the role of advisor on maternal, newborn and child health on the MTAPS project, which is Medicines, Technologies and Pharmaceutical Services, a project, USAID funded project implemented by MSH and partners. And I also work on some of the other projects that MSH has. I'm going to set the stage a little bit with a little bit of an introduction before I introduce and hand over to my colleague. So just to set the stage, as we all know, oxytocin is a life-saving medicine for women, and for it to be effective, it needs to be of quality and kept cold until the point of use. And this can be very complicated in low and middle income countries where refrigeration is difficult due to lack of fridges or power outage or even lack of power. And as we all know, UNICEF, WHO, and UNFPA have been great players in this field, and they've contributed greatly in this arena by making global statements. In 2015, a joint statement from UNICEF and WHO stated that oxytocin can be integrated into the expanded program of immunization cold chain if it's considered feasible, cost-effective, and safe. And in 2019, WHO and UNICEF joined with UNFPA, stating that oxytocin needs to be managed in the cold chain, that quality oxytocin needs to be procured, and that it should be labeled that it be stored and transported in the cold chain. So with that context, as Milka mentioned, MSH was awarded an innovation grant from the Reproductive Health Supplies Coalition through this caucus, the Maternal Health Supplies Caucus, in the middle of 2018 to facilitate the integration of oxytocin into the EPI cold chain in one country. And we aimed to create an enabling environment to conduct a policy options analysis, to secure political commitment, and to implement on a small scale in one country. And so to ensure that we would be successful, we mapped, first of all, the feasibility and acceptability in 3 countries, to then select out of those 3 the best country to move forward in based on a number of different factors. And so after mapping the strengths and weaknesses, the opportunities and threats, and evaluating the feasibility and acceptability, we selected Uganda to move forward in. And so the next steps of the grant were implemented in Uganda. And so with me on this webinar as a co-presenter, I have Eric Jamera Nabugusi, who is a technical advisor on the Uganda Health Supply Chain Program, UHSC, a USAID-funded program implemented by MSH in Uganda, obviously. So Eric has been leading the work in country once we moved on to the stage of selecting Uganda as where to move ahead in. So I'm going to move over to just passing the slides, moving them forward so that Eric can actually present the work in more detail that we supported in Uganda. So Eric, I'm going to put myself on mute and over to you.
Thank you, Jen. Thank you, Dinave. Good morning, colleagues, or good afternoon, wherever you are. I'm going to present a brief background about what we did in Uganda, our approach and achievements, and then conclude with lessons learned. I'll start by saying that PPH accounts for 42% of maternal deaths in Uganda. So given the effectiveness of uterotonics against PPH, it's a hugely significant step for us to be discussing integration as an important opportunity in the country. A 2016 study that was done in some low and middle income countries showed that about a third of the oxytocin available did not meet the expected quality standards. Now for oxytocin, one of the requirements is that it is kept between 2 to 8 degrees, so it should be kept cold in order to keep its potency. And we know that this is one of the contributing factors to maintaining its potency. 50% of deliveries in Uganda occur at primary level care facilities, and these primary level care facilities for us are health center 2s and 3s. In principle or in general, the cold chain infrastructure is particularly weak in health facilities, and more so particularly weakest at the lower level facilities. These facilities need this integration process in order to keep the oxytocin and maintain the potency of the product. The lower level facilities, the health center 2, which generally does not have a fridge, will use misoprostol as the second line drug. We conducted this activity in 3 phases. The first phase was a scoping phase to assess feasibility and acceptability of the integration process. This was done through engaging with a number of key informants. The second phase began with a stakeholder engagement process. It began the stakeholder engagement process. First, we did a rapid assessment, which was an online tool. So we administered it online. We received feedback from about 183 health facilities from over 60 districts in the country. The rapid assessment was essentially to understand 2 things. One was availability of cold storage facilities, and then 2 was the oxytocin storage practices in those facilities. The second activity we did was a policy options analysis to consider and get consensus on where and how to go about the integration process. The outcomes of that activity were for us to understand what the enablers, the barriers and recommendations were to move forward with the integration process. Second outcome was for us to establish an integration task force to take this activity forward. And the integration task force led a process of developing guidelines, SOPs, and other tools that were then used in phase 3. Our phase 3 was a learning phase, which we implemented in two districts. This led to a process of adaptation, testing, and feedback around the guidelines, the tools, and the different materials we had developed. And the final materials we're at a stage where right now the final materials have been submitted to the Ministry of Health. I'll speak to that more in a second. Next slide. And probably just to emphasize, slide back, just to emphasize that throughout the process, we had to maintain close contact with the Ministry of Health technical working groups. And the 3 technical working groups here are the one for immunization, another for maternal and child health, and the other for medicines procurement and management. Next slide. So prior to this activity, Uganda had made some strides towards integration. Led by PATH around 2016-2017, some initial advocacy activities had been done, and this culminated in the Ministry of Health issuing a directive in 2017 to allow oxytocin to be stored together with vaccines in the health facilities in response to the weaknesses in the cold chain. We also had a job aid developed to support the implementation, though it was not well disseminated. However, a number of central level actions were triggered by this directive. Our UNEP program, the EPI program, procured over 600 fridges at the time that included a container for oxytocin storage. And while the job aid was not used at the time, it was important in the following in the development of the guidelines and SOPs that we developed later on. Next slide, please. So this shows the range of stakeholders that need to be involved and engaged in the integration discussions. It's fairly complex when you consider the process from procurement, warehousing, distribution through to the rest of the supply chain. So it's fairly complex, and it's important that stakeholders are engaged. However, for Uganda, we had a number of pieces that fell together for us to move forward with the integration. First, the National Drug Authority already around 2015-2016 had passed a requirement that for registration of oxytocin, that its primary pack should have a label that indicates storage at 2 to 8 degrees. So we didn't have anything around the so-called heat-stable oxytocin in the country. Secondly, we had an opportunity that national medical stores was storing and distributing both vaccines and essential medicines, which include oxytocin. The other opportunity we had is that in general, there is good, the cold chain infrastructure for vaccines is quite good and quite efficient. Then again, I mentioned in 2017, we had the directive from the Ministry of Health. So this was the political support or the policy makers' support towards the integration process. Then UNEP had gone ahead to procure the fridges in 2018, and we are now in the process of procuring close to 1,000 fridges that started in 2019 that also have a storage container for oxytocin. There was a lot of advocacy work that had already been done, and the job aid, though poorly disseminated, had been developed. And included, one of the requirements from the job aid was to have the separation of oxytocin using those containers that were put in the EPI fridges. And of course, we had donor support for the entire integration process. These are some of the findings from the rapid assessment. First, we found that the vaccine fridges were generally available in health facilities, close over 98%, so you can say it was they were ubiquitously available. However, the cold storage facilities for essential medicines where oxytocin falls, only 40% of facilities reported having these fridges. So this already indicated to us that 60% of facilities lack alternative cold storage facilities out of what is available under the vaccines system. Examining where this 40% is in a little more detail, You can see that our regional referral, general referral hospitals, and health center 4s are generally equipped with refrigerators, while the health center 2s and 3s generally did not have fridges. Contrast this with the fact that I mentioned earlier, 50% of deliveries are being done at this level. The rapid assessment showed a number of other findings, but principally pointing to the fact that without guidelines accompanying the directive from Ministry of Health, implementation was fairly haphazard, or rather differed significantly from one facility to another in the country. The options analysis that we did, it's important to look at the integration process holistically. So you look at what happens from the central stores to the district, the transportation system, right up to the health facility, as well as the management of the commodities at the facility itself. So, and note that integration can really take place at any point along the supply chain. So in Uganda, we considered 3 options. One was the facility only. A second was to do it at the district and health facility. And the third was to look at integration holistically. The decision around the final option to take based on these 3 factors. One, that NMS that does store and transport oxytocin was doing it perfectly in cold chain up to where it delivers to the district. So our risk with respect to oxytocin cold chain started from the district, transportation to the health facility, and how the commodity is eventually handled at the facility level. So we selected the option of integration at district and health facility level for these reasons. The options analysis also revealed some concerns of the stakeholders. One, that not all facilities were aware about the Ministry of Health directive. We found that there was a gap in this. And secondly, because there were no standardized procedures accompanying the cold storage directive, facilities developed some locally developed guidelines on how they would implement this. When we looked at how this was being done at the different facilities, there were significant differences. So that created a need for this process. Then thirdly, there was a concern that integration of oxytocin could actually compromise the vaccine's cold chain, and there was need to have effective separation of the commodities. Those who have looked at an oxytocin vial and a BCG diluent, they look quite similar. So it was important that these products are effectively separated to minimize any accidental administration of either product. Lastly, there was concern that integration would impose some constraints on the available storage space, recognizing that UNEP had just finalized its cold storage forecast for the next 5 years. And in that forecast, there were plans to expand the range of vaccines that would be made available through the program. Next slide. So a bit on our achievements. One is that we managed to establish a multi-stakeholder integration task force. This was important to bring together players in MNCH, EPI, and supply chain, and the different partnerships that each of those have to work together towards integration. And then second, the task force then went about the task of developing guidelines and tools. We did develop comprehensive guidelines, tools, and SOPs and visual aids. I'll show some of the visual aids shortly. We also prepared a checklist that a district or health facility could administer on itself to assess their preparedness to implement the process. We completed the learning phase, doing a pilot for about 6 months. The period of 6 months was sufficient because we were not introducing new products to the system, but rather a new way of handling them. And then the final phase, where we had adaptation of the materials. Ministry of Health developed a scale-up plan, and we're currently at a stage pending Ministry of Health approval by the senior management of Ministry of Health for the scale-up to be done by the different partners that have already committed to scale up. To institutionalize these materials, we have planned that in future, when we're revising guidelines for PPH, for immunization and essential medicines, we'll integrate these guidelines into those existing tools so that we do not have a standalone guideline like we have at the moment. Next slide. This is just to show you the implementation manual that we developed. It's table of contents and a supervision checklist on your extreme right. The manual did include the SOPs. Then these are some of the visual aids that were developed, and maybe I should walk you through what we actually adopted as the procedure. National Medical Stores delivers Oxytocin up to the district level. From there, the Oxytocin is transferred to the district vaccine store. Here there are multiple fridges, and they would pick one where Oxytocin could be kept until it had to be delivered. Our districts act as a cross-docking point from where deliveries to the individual facilities is done over a number of days. So the cold chain technicians in the DVS would then be responsible to pack Oxytocin in cold boxes with ice packs and a temperature monitoring device and hand this to the transporter to take to the facility. At the facility, Oxytocin would be kept in the vaccine fridge, in a container, in one of those containers that we described earlier. Those containers would be labeled Oxytocin in a clear marking so that they're well and easily identified. And then from there, the midwives on the maternity ward would periodically order Oxytocin to keep small quantities on the ward. Now, on the ward, Oxytocin would be kept in a cold box. In our case, we used vaccine carriers, and then have the ice packs changed twice a day in order to keep the Oxytocin cold when it is on the ward. On the next slide, you'll see some of the pictures. So on the left-hand side is a container that was procured with the fridge. It has a lid, but just to show you what it looks like. And then these are only 600 fridges. So for the other 3,000 or so, where we don't yet have fridges with these containers, facilities were able to improvise some containers, as you can see on the right-hand side. Next slide. And here is a picture. One of the changes that we made was that the Oxytocin stock card would no longer be kept in the fridge, I mean in the store, but it would be kept on the fridge. So here we had a stock card that was taped on top of the fridge so that every time you opened and closed, it would be in your face to update it. The second picture in the middle is showing Oxytocin, a few vials being kept on the maternity ward with the freshly changed ice packs. And then one of the tools that was developed to help track that the ice packs are actually being regularly changed and that Oxytocin is being ordered periodically from the fridge. We recommended that the maternity ward keeps about 48 hours supply of Oxytocin, enough to run them through a night shift and part of the next day where necessary. So what were some of the lessons learned from this process? One is that stakeholder engagement is very important and vital in getting this exercise to its fruitful conclusion. As I indicated, the range of stakeholders is likely to be very diverse, and they need to be on the same page. You need to manage the expectations, and you need to be clear on why the integration needs to occur, so that when you get into what actions eventually need to be done or written into the implementation process, these are clear from the get-go. In the case of Uganda, our reasons for integration was because we're only looking at those areas where the cold chain was compromised, and that was at the district and facility level. So we rallied our activities around streamlining processes at those two levels to ensure that oxytocin is kept cold. The second lesson was to look at this from a system-wide lens, a holistic approach, because the implementation is going to require some people to take on new roles. We had the example there of our immunization focal persons at the health facilities would now need to take responsibility for filling out stock cards and resupply of the maternity wards. At the district level, the district cold chain technicians were also taking on new roles. There will be need for sensitization, for training to be done at different levels. There will be need for some training as well. So it's important to look at this from a holistic point of view. The other thing is that much as we had a directive to implement oxytocin cold storage, we found that it's important to have implementation guidelines. These guidelines, we found that actually would then help the different users to operationalize the policy around integration. We found that places where this was clear, in fact, in all the places we piloted where this was made clear, it was easy for the health workers to act on what they were supposed to act on. And the visual aids that we developed were then acting as quick references for the health workers to refer to whenever they were doing their actions. Okay, next slide. The other lessons we learned were around the importance of implementing and sensitizing all levels of care about the integration process. During our learning phase, we targeted mainly the health center 2s and 3s because this was where the shortage of fridges were. However, during our implementation, we found that even where we found refrigerators at the higher levels, there were risks to the cold chain. Power outages were commonly found, and the EPI team, for instance, had all fridges installed with an alternative backup power source, whereas the fridges for essential medicines did not always have an alternative power source, backup power source. Also on the ward, there is no fridge on the maternity ward, so it was important that they would use the foam that we talked about earlier to help keep the oxytocin cold on the ward, which is the very next lesson that we learned, that in order to keep oxytocin cold on the maternity ward, there was need for a foam that tracks this process. You're aware that maternity wards are working 24 hours a day, and this is a rotating shift of midwives. So having a tool like this that they could quickly refer to as they change shifts to know how much oxytocin is available on the ward and make a decision on to reorder if necessary, and also to check on the need to whether the ice packs had been changed or needed to be changed, and take that action immediately. So this tool was very important, and I think one of the game changers when it came to keeping oxytocin cold at the service delivery point. The other lesson is to watch for implicit and explicit resistance. There are cases where you just have inertia to implementation. It could be at the central level, it could be at the district level. While in other cases it is overt, and The important thing is to take note of wherever this happens, watch for it, and have a strategy to deal with it. In our case, it was typically a need to sensitize, provide the information to such people where we identified them, and many of them actually turned into supporters later on in implementation and made our activity move forward quite smoothly. The last point I will touch on is the need for joint planning for cold storage space. As I indicated, the EPI program is expanding the range of vaccines that they will be providing, while the integration process also does pose a demand on this cold storage space. So there's need for these stakeholders to sit together and plan for these these resources, including the storage containers for those places where the new fridges have not yet been delivered. In terms of way forward, next slide. For us, our way forward is that we are currently at a stage waiting for approval by the Ministry of Health senior management. This has been tabled. We expect the approval to come through in the course of April. We already have several partners and donors aligned to the scale-up plan that was developed and have expressed their intent to support the scale-up in the districts where they are present. Some have actually already started on this to some minuscule levels. Second, given the challenges that we saw at higher level facilities, it's important the expansion phase targets all levels of care so that everybody is sensitive to the fact that oxytocin needs to be called right up to the service delivery level, the service delivery point. And then lastly, the tools that we developed, we introduced 2 new tools, the oxytocin storage form I've talked about. The other is the cold chain equipment tracker used at the district vaccine store. This is a tool to help track the equipment that is lent out of the district vaccine store to the transporters. The cold boxes, temperature monitoring devices need to be returned to the DVS. So this tool helps track those commodities. And I'll also hasten to add that this tool was not just developed to help with oxytocin integration. The tool is actually universal and can be used for any other circumstances where the cold chain equipment need to be borrowed from the district vaccine store. So we have commitment from Ministry of Health to adopt these tools into the HMIS manual once it is next opportunity to include new tools to them to be done. Thank you. That's the end of the presentation. Jane, over to you.
Great. Thank you very much, Eric. You have given us a run through of 1.5 years worth of work in just over 20-25 minutes. So I think that was a very clear presentation. Thank you for sharing with us everything that we worked on in Uganda. Just before I open up to questions, and I see that there's a few questions that have been coming in already, so do continue to write your questions in the chat box for questions. But just a couple of kind of closing remarks to give us something to think about as we're digesting the work that Eric presented. First of all, we will be looking at how we can disseminate the work that was done in Uganda, so the tools and the guidelines that were developed, although they are obviously context specific to Uganda. We will be looking where we can post those so that they are freely available so that other countries can get inspiration from them, adapt them as necessary. And we are hoping to get them translated into French also through one of our other projects. I don't see that we would be able to get them done in Spanish as well, Milka, but I'll let you think if there's any way of getting them translated into Spanish if that is helpful. The other point that I think is really important to stress that Eric mentioned a number of times is the involvement of stakeholders. And I think it's really important to stress that the success of the work in Uganda, and I think Eric said we're still waiting for the Ministry of Health approval, that's basically just the bureaucratic step of signing off on how this is going to be implemented. But all of the actual implementation levels of the ministry have approved and validated this whole approach because they've all been so involved with it from the very beginning. And that shows the value of the multi-stakeholder task force that Eric described as part of our approach. And really managing their contributions, managing the expectations, and getting them all involved was really crucial. And I think one of the things that Eric alluded to is that in the beginning there were some key stakeholders that were fairly negative about this whole approach, despite the fact that the ministry had issued the directive back in 2017. And that negativity kind of spread throughout the whole health system with different healthcare providers and different workers at different levels. And through this stakeholder engagement, that negativity was able to be changed into positive forces. And really some of those people that were against the approach from the beginning ended up being some of our sort of greater champions in taking this approach forward. And so I think the ownership and the involvement of stakeholders has been essential in moving this forward. And linked to that, I guess, is the leadership of the country itself. And the Ministry of Health in Uganda has been clear from the beginning what their position was. They issued the directive that they wanted oxytocin to be integrated into the vaccine cold chain as a kind of measure for the meantime until they resolved what would happen with the cold chain for essential medicines, which is a much bigger problem. And so they really were an example of leadership in this issue. They were the ones that were insisting that they wanted oxytocin containers as part of their fridges, so including that specification in the procurement that Gavi was supporting. So the leadership of the country was really important, and they just needed support in how to operationalize what their vision was. And so that's where we have played a role to really get the different stakeholders together and work out how to operationalize it. And that's what Eric has been presenting. And maybe another comment on the involvement of other partners is, I think a number of people along the way have said, you know, we're not just kind of using the vaccine cold chain and that's the solution to the problem. There's a real importance of the role of other partners that aren't involved in the vaccine cold chain to play their role and to provide resources to support the integration of oxytocin into the cold chain. We can't just sit back and say, okay, vaccination will manage this. And so obviously in the orientation and training of staff in their different roles, printing of materials, Eric showed a number of different tools and guidance documents that would be helpful in integrating oxytocin into the vaccine cold chain in a standardized way rather than it being sort of fairly ad hoc. The oxytocin containers, obviously we saw the pictures of the fridges that have the oxytocin containers built in or already in the fridges, but where there were not those special fridges, other ideas, other resources had to be used to keep the oxytocin separate. So we can't just kind of wash our hands of it and say, okay, it's in the vaccine cold chain, everything's fine. There's a real kind of two-way relationship with the immunization partners and the non-immunization partners. And when I say partners, I'm meaning obviously the Ministry of Health entities and groups, as well as the implementing partners that support it. And now just a minute just to think about the stakeholder involvement at the global level. And I think we've shown a nice example of how Gavi was involved in this initiative and was supporting the Ministry of Health vision with the procurement of the fridges with the oxytocin containers. And I think it is important for all of us to, we all represent different organizations, but how we speak with one voice across all levels. And so where we have support for this kind of integration at the global level, to make sure that that's reflected at the country level through the in-country representatives that we all have as partners. And should we be doing more at the global level to engage with Gavi and UNICEF in the vaccine space to look at capacity of fridges and requirements for storage and so on? So is there something that we as the maternal health community, is there something more that we can be doing at the global level as well? And I think one thing that Eric didn't have time to go into in the presentation was the issue of oxytocin has really kind of highlighted that it isn't only oxytocin that needs a reliable cold chain, and that there are other medical products that need cold chain storage, insulin, lab products, blood products, et cetera, And so kind of moving on from this, we need to be able to help countries to look at the space that's needed, how to keep those products cold. And this is a discussion that's already starting in Uganda as to how they can consider the other medical products that probably won't fit into the vaccine cold chain, and what the opportunities there are for how to strengthen the cold chain for essential medical products. There's already a network of maintenance and repair for the vaccine fridges. Can that be applied to non-vaccine fridges? Obviously, the procurement of additional fridges is a big issue as well. But what can we be doing to look at those opportunities to strengthen cold chain for other medical products as well? So I'm going to leave it there. We've had the presentation, a few closing remarks, and with that, I'm going to hand over to you, Milka, to open the floor to questions.
Thank you so much, Jane. I wanted to make just a couple comments from the management of this Innovation Fund project. Eric and Jane have shown us quite a smooth process, but this was not a smooth process. The amount of work, of time, and of funding of this project was totally underestimated by us when we started the project. So if anybody wants to do this kind of project, make sure that you estimate the cost of convincing people of the value of integration of the supply of the cold chain, and estimate that value and the time it takes. We had to extend this project a couple times, and we in the beginning we had 3 countries, and we finally were able only to work with 1 country, which was politically prepared, and that was Uganda. So I just want to make a point that this was not an easy task, and the results that Eric and Jane have obtained are wonderful. We have a lot of questions. The first one from Stani Bansimana. Stani from the University of Rwanda, the Center of Excellence for Vaccines, Immunization, and Health Supply Chain Management. If 40% reported to have capacity, that is fridges for storage of oxytocin, where did health facilities kept their vaccines in the remaining 60% facilities? Did you find a case whereby in one health facility a kind of gentleman's agreement where EPI staff at health facility accepted to store oxytocin for another department? What say you, Eric?
Okay, thank you, Stani, for the question. First of all, the 40% were 40% of facilities that had refrigerators for essential medicines. For vaccines, the vaccine fridges were available in almost all the health facilities. It's important for me to remark that the question we asked was whether the fridges are available, not whether they also are functional. Okay, so functionality is a different question. And yes, following the directive, yes, we found that oxytocin was being kept in the vaccine fridges in a number of facilities. The questions that then came around was which part of the fridge should we keep the oxytocin? Should it be the coldest part? Should it be the nearest to the door where it's probably not exposed to the coldest temperatures? So these were the types of questions that were not clear to the health workers. How often should they pick oxytocin from the fridge? You're aware that the vaccine people are quite sensitive to how often the fridge should be opened in order not to affect the temperatures too much throughout the day. Whereas babies are coming and arriving as often as they need to. So there were just a number of disparities in terms of how the health workers were able to implement the oxytocin storage in the vaccine fridges.
Thank you so much, Eric. The second question is probably one of my favorite questions, and I hope, Jane, that you can clarify this one. What is the update on temperature stable oxytocin versus refrigerated oxytocin? And this is a question from Maxwell Casonde. Can you clarify, Jane?
I can certainly start, and I know that there are others on the call that can add to this, but my reaction would be that there is no temperature stable oxytocin. All oxytocin needs to be stored in the fridge. While there is some evidence to show that it can be kept out of the fridge for a very limited time, when you think of the length of the supply chain, you don't know how long it's been out of the fridge at any point along the supply chain, whether that was in the containers in the ship, whether that was in the trucks going to the central medical stores. And so there is no temperature stable oxytocin, and all oxytocin should be stored in the fridge and should be labeled as such, which is what the joint statement from WHO, UNICEF and UNFPA states in 2019. I think in Malawi there is some interesting work to be done to talk those points through. I think that there are other projects that will be working on that. We did discover this issue in Malawi and probably other countries as well. I'm going to leave it there. I don't know. I see that Jeff's on the line, and Milka, if you want to add anything to that response.
Yes, I would like to invite Maxwell to visit the website of the Maternal Health Supplies Caucus of the Reproductive Health Supplies Coalition. In that website, you will find the enormous amount of evidence that says that oxytocin should always be refrigerated. There is no such concept as temperature stable oxytocin. If you read the small letters in the inserts of those boxes of heat stable that claim to be heat stable oxytocin, you will see that it says very clearly, not more than 6 months, no more than 25 Celsius. And in none of our countries, and I'm living in Lima, Peru, in none of our southern countries, we have 6 months of 25 Celsius, ever. So please, don't ever think that there is a temperature stable oxytocin. There is an amount of evidence that the United States Pharmacopoeia has gathered, that Monash University from Australia has gathered with samples in Ethiopia, in Nigeria, in Bangladesh, in many countries where it has been totally proven that there is no such heat stable oxytocin. So I would refer you to our website and please do leave that concept of stability with oxytocin. There are 3 questions here from Jeff Jacobs from Merck for Mothers. So I'll read the 3 of them. So Eric, if you want to take note. First question. Thank you, Eric. You mentioned some concern at district and lower levels regarding limited space for current future vaccines if oxytocin is integrated. Does this concern also go beyond oxytocin? That, for example, does it also, the concern is on insulin, on test kit regions, HIV meds, others? That's question number 1. The second question, was there a discussion about somewhat mitigating the issues of weak cold chain, inconsistent electricity, limited refrigerator space by increasing access to heat-stable uterotonic alternatives? If yes, which uterotonic alternatives were considered? And the third, have the additional costs of this approach been quantified as it goes to national scale? Three important questions. Thank you, Jeff.
Yes, thank you, Jeff, for the questions. I'll start with the first one. The question about whether the space, the existing space in the fridges in lower level facilities was actually adequate to incorporate oxytocin. Okay, the oxytocin that those facilities required. There was for most facilities that we visited, it was not a challenge. However, when you move to some of the busier facilities, let's say doing close to 120, 150 baths in a month, you'd find that that's when you are likely to start encountering space constraints in the fridge. Was this affecting other commodities? Definitely, where there is a constraint, it would also affect other commodities. We found that in these facilities, they were already, I would say quietly stealing the refrigerator space and keeping there the other temperature sensitive products that they were receiving at the lower level facilities. So yes, there has to be a bigger discussion around the planning for temperature sensitive commodities throughout the supply chain, even beyond oxytocin. The second question was around heat stable alternative uterotonics. Yes, at the central level, we have begun discussions to incorporate heat stable carbetocin as an alternative for prevention of PPH. You are aware it does not treat PPH. The other heat stable commodity we have is misoprostol, and according to our guidelines, is available at all levels of care. And also, last year we passed a guidance that would enable it to be used even at community level, and the guidance of a health worker. So this is really at early stages of discussion at the moment. However, it's an opportunity because in Uganda, we are due to revise our clinical guidelines and essential medicines list in 2020. So if this meets if these decisions are made within the same timeline, we're likely to have that as an alternative. Additional cost as a result of the integration. The integration is not introducing a cost to the system beyond what you need to do to train, sensitize different health workers, and possibly print some of these materials that are needed, the tools and the visual aids and SOPs perhaps that need to be available to health workers. But in principle, there is no additional cost to the actual physical movement of the commodities as a result of the integration process. I'll stop there for now. Jane, you want to add anything?
Any other comments, Jane? Yes?
No, I think Eric has captured it. I think that in terms of the additional costs, obviously the training and the printing is an additional cost, but that is something that was discussed quite extensively in the validation workshop that was held in December. And it is part of the sort of ministry's rollout plan and is part of the support that they will be expecting from donors and implementing partners. Those costs haven't been quantified as such, but they are understood as an additional cost. I think that's as much as I can add at this time.
Yeah, it's the total cost of the technical assistance, right? The staff time, the printing of the materials, basically the whole staff time, the training. That's, I think, where the important cost is. And then
although that said, just to add to that, Milka, I think an important point that Eric made towards the end was that the vision of the ministry is that these elements be integrated into ongoing training on the management of PPH, ongoing training on other issues, and also into the guidelines as they get updated. And so while there is potentially an initial cost, those costs will become part of the package, and so won't be a sort of incremental cost.
Correct. And we have a second question from Stani. How did you find the behavior of the EPI staff due to adding oxytocin management in the routine work? Did you have cases of unhappy EPI staff due to extra workload or overload in their program? If yes, how did you manage?
So the EPI stuff, really, you need to unpack that to central level, and then district level, and then facility level. So in general, I would say we had strong support from the program manager of the immunization program in Uganda. He was a strong advocate for the integration process. The work concerns from other staff on the program, which I presented in the slides, because immunization is a highly reputational program. It depends very much on having a strong reputation. So those were some of the concerns that they had that we went ahead to consider and address in developing the implementation guidelines. At district level, we had a mixed picture. Generally, in the districts where we implemented, they were supportive, though the scoping study did show that there were some mixed messages reaching the health facility. There were some district personnel that were communicating that this was detrimental to the vaccine program. As you can imagine, changing a system where the instruction for vaccine fridges has been that nothing else apart from vaccines should ever go into the vaccine fridge. This has been a standing instruction for decades. So changing that mentality, I think there is some work to be done to change that. With respect to workload at the facility level, this was not so much of a problem. Quite often, the immunization focal person was happy to learn how to use a stock card if they had not encountered them. But when you go down to these lower level facilities, because it's a fairly skeleton staff in terms of numbers, the health workers you encounter there are usually doing multiple tasks. So it was not uncommon, for example, to find that the immunization focal person at the health facility is also a midwife who works on the maternity unit. So because of some of these shared roles, they were already sensitized to doing this work. We didn't really see or encounter too many challenges at the health facility that could not be dealt with through sensitization and information. The bigger challenge, I would say, was at the district level, getting the district level personnel on board, especially the district vaccine store personnel and the transporters to work together was a very new thing in how they work, because vaccines are delivered up to the district, and then the district makes arrangement for their onward delivery, whereas essential medicines, NMS delivers these up to the health facility through a transporter that they've contracted. So those differences in the product characteristics with respect to the supply chain did introduce some complexity to deal with for the implementation. But by and large, like I said, we had the support of the Ministry of Health for implementation, meant that we were able to pass on the message without too many hurdles.
So,
I hope that answers that question.
Thank you, Eric, so much. We have come to the last part. We are 1 minute over the hour. So I want to thank both of you, Eric Jamera and Jane Briggs, for this wonderful presentation. And I especially want to thank you for the very hard work that you have done under the Innovation Fund. With this, I would like Jane to say the closing remarks, and to all of you out there, stay healthy, and we hope to see you again very soon in a new webinar. I have posted both in the questions and in the chat box the website for the Maternal Health Supplies Caucus for all its materials, especially on oxytocin. So, Jane, closing remarks.
I think you've already summed up, Milka, but maybe just to say that if anybody has any further questions or needs more information on any of the work that was done, please feel free to reach out to Eric and myself. The emails are on the first slide, I believe. And we will certainly be looking at ways of sharing the work that, the documents that were produced with the wider community through different websites. So we'll be communicating that through the Maternal Health Supplies Caucus and other mechanisms as well. Thank you for your attention, and let's keep doing all we can to buy quality oxytocin and keep it cold. Thank you.
Thank you. Bye-bye.